So before discussing the new sepsis guidelines, let me show you two different patients admitted to the emergency department. Please go through the clinical details of these patients and try to answer a simple question. First patient, Robert, 60-year-old, admitted to the emergency department with high-grade fever, total count of 25,000, CRP 300, and a normal blood pressure, and a high-grade fever of 103. All other investigations were within normal limits. Second patient, Wilson, is a 34-year-old male admitted with lower abdominal pain and features suggestive of acute diarrheal illness. Both total count and CRP elevated, procalcitonin 9. At the time of admission, BP was only 90/60 but fluid responsive, and he is febrile. All other investigations were within the normal limits. Both patients are on room air. Now the question is very simple. Out of these two patients, who has sepsis? And the answer is also simple. None of the above patients has sepsis. Why? Because to answer this, we need to know the definition of sepsis. See this. These are microorganisms like bacteria, viruses and fungi that can cause infection if they enter our body. Normally, our body or the host responds by trying to kill these organisms. This is called the normal host response. But in sepsis, there is a dysregulated host response to infection. Meaning, dysregulated means that the body is functioning abnormally. This abnormal response can lead to organ dysfunction. For example, the kidneys are not functioning properly. Their functions become deranged. This organ dysfunction can be life-threatening, meaning the patient can die. So we'll read from this side. Sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to infection. Sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to infection. So now look at these two patients. None of them show evidence of organ dysfunction. So how do we determine whether organ dysfunction has occurred? For that, we can use a clinical tool known as the SOFA score to assess or identify organ dysfunction. So what is SOFA score? SOFA stands for Sequential Organ Failure Assessment Score. Sequential implies that the score is measured repeatedly over time to monitor the progression or improvement of organ dysfunction. The SOFA score assesses 6 organ systems. For respiratory, we assess oxygenation. Coagulation, we monitor platelet count. And for liver, we assess for raised bilirubin level. And for cardiovascular system, we look for hypertension. And for central nervous system, we assess the GCS. And for kidney or renal, we monitor for elevated creatinine levels or reduced urine output. So organ dysfunction is defined as an acute increase in SOFA score by 2 or more points in the context of suspected or confirmed infection. So when we suspect infection in a patient presenting with features like fever, elevated WBC count or symptoms suggesting infection. And when do we confirm infection? Confirmation can be through a positive culture or other diagnostic evidence. So what is sepsis? Sepsis is defined as a life-threatening organ dysfunction caused by a dysregulated host response to infection. So organ dysfunction should be there to tell a patient to have sepsis. In clinical terms, it means suspected or confirmed infection and an acute increase in SOFA score by more than 2 points. So now what is septic shock? Take a look at this case. This patient was admitted with fever and has evidence of sepsis, meaning the SOFA score is more than 2. His blood pressure was only 80/60 even after giving adequate fluid boluses. So now he is requiring medication to maintain blood pressure. So basically, septic shock means a patient with sepsis has low blood pressure that does not improve even after adequate fluid resuscitation and now requires vasopressors to maintain a MAP of more than 65. In addition, serum lactate is elevated despite adequate fluid resuscitation. Why is lactate high in septic shock? Due to low blood pressure, oxygen delivery to tissues is reduced. As a result, cells switch from aerobic metabolism to anaerobic, which produces lactic acid as a byproduct, hence the elevated lactate levels. So the definition of septic shock is the subset of sepsis in which cellular metabolic abnormalities are profound enough to increase mortality. Now see this. This patient has presented with septic shock. The blood pressure is only 70 systolic. So here are a few frequently asked questions. Which fluid should be given and how much in septic shock? So we'll start with 30 ml per kilogram body weight of IV crystalloids within the first 3 hours based on the actual body weight, to be given as rapidly as possible, and the preferred fluid is balanced crystalloids like ringer lactate or plasmalite. For example, so for a 70 kilogram adult we have to give around 2 liters within the first 3 hours. And ongoing fluid management. After the initial fluid bolus, assess fluid responsiveness before administering more fluids. Our goal is to maintain a MAP of more than 65. And also ensure urine output of more than 0.5 ml per kilogram body weight per hour, and monitor for improved mentation and also lactate clearance. And if MAP remains less than 65 after adequate fluids, consider starting vasopressors. So which medication is used as a first line treatment to increase blood pressure in septic shock? Noradrenaline remains the first line vasopressor. Vasopressin is only added when noradrenaline alone is insufficient. Adrenaline is another alternative if needed. So another question is when to start antibiotics in sepsis. If you are sure that the patient has sepsis, that is suspected or confirmed infection and organ dysfunction such as an increased SOFA score of more than 2, administer antibiotics within 1 hour. And also if the patient has septic shock, give antibiotics within 1 hour. But if you are not sure the patient has sepsis, but you suspect it, assess and reassess and try to find whether the patient has sepsis and administer antibiotics within 3 hours. Before giving antibiotics, don't forget to draw cultures. Is there any role for albumin in sepsis? Albumin is a colloid fluid used selectively in septic shock. It may help with volume expansion and maintaining oncotic pressure, especially when large volumes of crystalloids are insufficient. So when to use albumin in septic shock? Consider albumin if persistent hypotension remains even after administering 30 ml per kilogram of crystalloids. Use in patients at high risk of fluid overload, those with congestive heart failure or CKD. Albumin 5% is preferred for resuscitation. Start with 100 to 300 ml bolus, repeat as needed. Albumin may reduce the total fluid requirement and capillary leakage, but it is costly. Is there any role for steroid in sepsis? Yes, steroids do have a role in septic shock, but they are not recommended for all sepsis patients. In case of septic shock refractory to vasopressors, low dose intravenous steroids can be initiated. Standard regimen includes hydrocortisone 200 mg per day, typically administered as 50 mg every 6th hourly or 100 mg IV bolus followed by a continuous infusion. So duration usually 5 to 7 days, then taper or stop based on clinical response. What is the rationale for using steroid? Some patients in septic shock develop relatively adrenal insufficiency, also known as the critical illness related corticosteroid insufficiency. And so steroid may help restore vascular tone, reduce vasopressor requirement, improve mean arterial pressure and possibly shorten ICU stay. Is there any role for high flow nasal cannula or HFNC in sepsis? In adults with sepsis induced hypoxic respiratory failure, HFNC is preferred over standard oxygen therapy. Why? Because HFNC provide higher, more stable oxygen and some degree of positive airway pressure, improve patient comfort and reduce workup breathing. So HFNC can reduce the need for intubation in selected patients. Now what practices are discouraged or are not recommended in sepsis guideline? Vitamin C not recommended due to lack of consistent evidence for improved outcome. Use of colloids like hydroxyl ethyl starch not recommended due to risk of kidney injury and mortality. Early use of vasopressin as first line agent not recommended. Routine use of IV immunoglobulins not recommended. Use of dopamine as a vasopressor not recommended due to high risk of arrhythmias compared to noradrenaline. Use of sodium bicarbonate for lactic acidosis not recommended. Routine use of blood purification techniques like hemoabsorption or cytokine filters not supported due to lack of sufficient evidence. Procalcitonin for starting antibiotics should not be used to decide when to start antibiotics. May be used to support decision to stop or de-escalate in certain cases. Early goal-directed therapy as per reverse protocol no longer recommended. Sigris not recommended. HAT therapy not recommended. So now what is NEWS and MUSE? NEWS or the National Early Warning Score. NEWS is the preferred screening tool in modern sepsis guidelines. Here we use 7 parameters like respiratory rate, oxygen saturation, use of supplemental oxygen, temperature, systolic blood pressure, heart rate and level of consciousness. If NEWS value is equal or more than 5, think possible sepsis, initiate sepsis screening and start treatment immediately. And what is MUSE? Here in MUSE we use only 5 parameters like respiratory rate, heart rate, blood pressure, temperature and conscious level. If the value is more than 5, high risk ICU transfer often considered. MUSE is simpler but still useful, especially when NEWS isn't implemented. What is the role of ulinostatin in sepsis? Ulinostatin is a protease inhibitor derived from human urine. It inhibits enzymes like trypsin, elastase, and inflammatory mediators, but not globally recommended as standard therapy due to limited high quality evidence. What is the role of methylene blue in sepsis? Methylene blue used experimentally in refractory septic shock, particularly when vasopressors fails, but not included in standard sepsis management guidelines. How does capillary refill time compare to serum lactate in assessing perfusion in sepsis? Capillary refill time is a quick, non-invasive bedside tool to assess peripheral perfusion in sepsis, while lactate is a lab marker reflecting global tissue hypoxia. So capillary refill time can be used to guide resuscitation, especially in resource limit setting, and has shown non-inferior outcomes compared to lactate. Which year was the last update of Surviving Sepsis campaign? So the Surviving Sepsis campaign guideline was first published in 2004 and the most recent version was released in 2021, and the 24-25 update is expected to be published shortly.